Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specializing in NICU education. Today is the fourth Tuesday of August, so our final redo of some previous posts as we celebrate the 1-year anniversary of Houston We Have A, which is both on Instagram and here on YouTube and of course on TikTok. So thank you for joining me. Today we are going to delve into the most requested topic. I asked on Instagram, what do you all want to see me redo during the month of August as we celebrate this 1-year anniversary of learning together? And ventilation versus oxygenation was brought up. I encourage you, there are maybe 3 or 4 appropriate contributing previous Teach Me Tuesdays that you can find here on my YouTube page. Go back, rewatch some of those videos. There's some specifically on conventional ventilation and ventilators, high frequency ventilation, regular ventilation. There's x-rays on other ones. This one is going to be, again, a broad overview with some specifics. But if you want to dig into x-rays and some more disease processes, please make sure to check out those pages. But let's dive in. So we know that ventilation and oxygenation are critical. They are probably the 2 things we talk about the most in the NICU. Probably followed closely by feeding, in both enteral feeding with your feeding tube and with your PO feeds, and parenteral feeding with your TPN and your central lines. But when we're speaking specifically about respiratory, we really are talking about ventilation and oxygenation. And the reason it's so important to remember the difference and to understand and to really kind of grasp these concepts is because they drive so much of what we're doing in the NICU and what you can anticipate being the next right step for your baby should something be going on with either ventilation or oxygenation. So ventilation is really this idea of removing CO2. How well do the lungs exchange gas? Whereas oxygenation is more about the process of delivering that oxygen that we've exchanged to the blood and to the tissues. So ventilation is how well the lungs are doing their job. It's the job's primary function is to exchange gases. And if I were to ask you, what's the number one way that we as human beings get rid of our CO2, your answer would be exhalation. Yes, our kidneys process some of that. We pee some of it out. We all know that, but that is not the primary way. And especially when you think about a premature baby with their immature kidneys, they're not going to be just peeing out their CO2 every time it gets high. In fact, their kidneys are probably going to shut down. So we must support ventilation to make the lungs do their job well. Oxygenation is really how well can the oxygen spread to all the organs. And if you have issues such as meconium aspiration syndrome, where there is just poop sitting in your alveoli, the oxygen can't get in. Or pneumothorax, where your lung has collapsed. The oxygen can't get in. So if the oxygen can't cross that little barrier and get into the capillary bed of the lungs and then spread out to the body, or you have a cardiac anomaly, which we went over 4 of those in the month of February, so you can also watch some of those, then we're not going to get oxygen to the body, into the tissues and organs as well. So that's kind of what we're talking about here. So let's dive into ventilation. So again, ventilation tells us how well the baby is exchanging gases. It's measured by your respiratory rate and your CO2 levels as your primary focus, and it's preventing respiratory acidosis. So keeping that pH in balance. We had lots of videos on blood gas interpretation. How do we improve our blood gases? But primarily respiratory acidosis, we are going to improve our blood gases by improving our ventilation. So some signs and symptoms that your baby may have poor ventilation include rising CO2 levels, that respiratory acidosis, so when your pH has dropped less than technically 735, but really we say less than 725, is way more common in NICUs. Increased work of breathing, so you're hearing grunting. Remember, grunting is a baby auto-peeping. They are trying to support their own ventilation by keeping their peep open, their alveoli open, by doing this auto peep where they're like, don't clap, don't clap, so we gotta stay open so we can exchange these gases, So that's your increased work of breathing. Your accessory muscles, such as intercostals, suprasternal, whatever it is that the baby's working really hard to breathe. your abnormal blood gases. So not only do we have respiratory acidosis, maybe we're compensating, so really looking at what your pH is doing. And then as your O2 requirements go up, it's also saying, hey, your ventilation is not going well. So poor ventilation requires an increase in your current support. So it might be that you're already on CPAP of 5 and you need to go to CPAP of 6, maybe CPAP of 7. A change in mode, maybe you're on CPAP and we need to increase it. Stimulation if the baby is apneic, and or medication. So medications, if this is a prolonged ventilation problem, could include steroids. If we need some extra help getting fluid off our lungs to help the lungs function better, maybe it's going to be diuretics. So just some medications we could use to help. Of course, caffeine, our old friend. So how do we help ventilation? So if your baby has a high CO2, they need a change. So I want you to think about what are they on and where can they go? And it's important to also think about if we're on a high amount of oxygen on any mode of these, is you really can't go higher than 100%. So if you're already on 60% on CPAP of 5, you should be panicking, right? That's a lot of oxygen for a CPAP. So if your baby's on room air, maybe they're on high humidity nasal cannula. Remember, that's just providing flow of oxygen. We're going to give them oxygen with some pressure. But high humidity nasal cannula is usually anywhere from 2 to 5 liters. It's not giving them a ton of flow, and it's not going to give them a big PEEP. So we might need to increase them to CPAP. So CPAP is usually set at a flow of 10. That's double what we're on with high humidity. And that's going to get you a PEEP of 6 or 7, 5, depending on what your machine is doing. And if you have a bubbler, right, they usually turn at the top. You can set CPAP on a ventilator. But it's going to help keep those airways open. It's going to prevent alveolar collapse. That way we can have the exchanging of those gases. Remember, if a baby is grunting and they're auto-peeping, they are going to tire out, and then we're going to get in a way worse place. We may then need to increase to some amount of non-invasive ventilation, whether that's NIMV or NAVA, whatever it is, where we can give them more support. We're going to give them a PEEP, a pressure. We're going to give them a rate. So this is also helpful with apneic babies because apnea is going to also affect your ventilation. And then we're giving them this rate and saying like, hey, we've got to breathe this much. But as we know, it's non-invasive. So they may need to get intubated because once we intubate them, all of that flow, the air, the pressure, the PEEP, all of it is going directly to the lungs instead of some of it being lost into the esophagus and into the stomach. Always have your OG in. Don't forget your OG. Key step. And then you will be on either SIMV, like a standard conventional ventilation, or a high frequency ventilation. Again, there's a whole previous YouTube Teach Me Tuesday on conventional ventilation and another one on high frequency ventilation, but we're getting controlled breaths. We're ensuring adequate gas exchange to help the baby through this. And as you see in this lovely little circle over here, if your baby is apneic, this is a ventilation problem. So as a NICU nurse for over 20 years, working at the bedside, being a preceptor, being a charge nurse, being an educator, all of those things, nothing frustrates me more than when you come up and a baby is apneic, there's no chest movement, they have started to become bradycardic on their alarm, maybe their saturations are going down, and someone's standing there and turning their oxygen up. You cannot bring a baby out of apnea with an increased amount of oxygen. They need stimulation. They need something to remind them to breathe. If you're on a ventilator, if you're on NIMV or NAVA, you can maybe give them a breath on the vent, right, as your form of stimulation. But we can't just sit there and turn up oxygen and hope that's going to miraculously help the baby. So apnea is a ventilation problem. Stimulate them, right? Give them a couple seconds to recover, right? 5, 6, 7. See if they're going to recover on their own. Make sure it's not periodic breathing, and then stimulate them. So that's ventilation. Now let's talk about oxygenation. So oxygenation in a NICU baby is this process of delivering oxygen to the bloodstream. We measure that primarily in our SpO2, right? Our lovely little blue guy that sits on our foot. On this little picture, the stock photo, you can see that this saturations are 97. So typically we're going to say we want them to stay between 88 and 95. If a baby's breathing room air, we can't control if they go to 100, but it's the most common measure of effective oxygenation. We want to prevent both hypoxia and hyperoxia. So with the OWL standards, right, effective oxygenation, we're trying to prevent ROP. If we give them too much oxygen and let them really sit up there in those premature babies, they're at risk for ROP. And if they sit too low, they're at risk for organ failure. Remember that oxygen is always going to deliver to the most vital organs first. So prolonged periods of hypoxia also increase our risk for neck, right? Because when our gut, our intestines get less oxygen, they are not going to be perfused enough to be able to move the food, fight bacteria, do all the things they need to do. So that's why we want to keep our oxygen in this safe zone. And yes, it's going to feel like there's times where you are chasing your oxygen. And no, I don't think you should tweak your oxygen every 30 seconds. That'd be crazy. Sometimes it's just not picking up because the baby's kicking, right? We're watching for trends. That's what we do in the NICU. We watch for trends and we respond to them. So getting in there, if your baby's sitting at 97, 98 for 2-3 minutes, we should probably turn their oxygen down. Maybe they just had an apneic event and you had to turn them up and the oxygen's slowly coming down on its own. Maybe you just finished your cares, you had to turn your oxygen up a little bit during the care time, let them recover, and then bring it back down. But again, we don't want them to sit too high for too long. So ways we improve our oxygenation, right, is supplemental oxygen given either nasal cannula, CPAP, or ventilator, adjusting that FiO2, that fraction of inspired oxygen. I always think it's important to remember what FiO2 stands for. So just saying like giving how much the baby is getting. And then we want to optimize this ventilation. If we have alveolar collapse, where's oxygen going to go, right? So we need to make sure that our ventilation is successful, right? This is how these two things work so closely together. We need to have effective ventilation in order for the oxygen to be able to get into the lungs, to get to the heart, to get to the body. So we might need to do positioning. I recommend over and over again, if your baby is new to the NICU and you're doing an admission and you've just done CPAP, maybe an IV, no umbilical lines, get them on their belly. They are going to breathe easier. There is this effect of gravity on their lungs. They are going to breathe easier, and I assure you that their oxygen requirements will drop. Okay, I'm not going to promise you because I don't believe in black and white in the NICU, as you know. But more than likely, you will see an improvement in your oxygen requirements for a baby who's positioned on their belly as opposed to a baby positioned on their back at the beginning of life with the fluids, everything trying to get off of them. It's called your ventilation oxygenation ratio, and it has to do with how the baby is positioned. So get them in a good position. And then they might also need surfactant, right? Depending on how old they are, whether they are a late preterm baby or a very small ELBW baby, they may need some surfactant to support their oxygenation. So keep those things in mind. So if we look at different disease processes, I'll let you pause here to read through this whole slide. I'm not going to read every bit to you. Primarily, we're going to talk about respiratory distress syndrome, right? So this is that deficiency of surfactant, which is the substance that keeps alveoli open. Surfactant is primarily produced, it starts around, because there's no black and white, 20, 22, 24 weeks, depending on the baby. The baby's going to continue to receive surfactant until administration, right, from their mom throughout. It's just going to build and build and build as they are gestating inside their mom. So we take them out early, and then we just cut off that supply. Other things that inhibit surfactant production include babies in IDM. So insulin deactivates that surfactant. So it makes your babies that are IDM more likely to have respiratory issues and have respiratory distress syndrome and need surfactant. So maybe also we had a mom who had a prolonged rupture of membranes, and that could be for weeks sometimes. And when that happens, then we're in this situation where the lungs didn't grow, maybe they weren't getting surfactant, they weren't getting fluid in there, so that's also going to affect our respiratory distress. So for ventilation support, we're going to use CPAP or mechanical ventilation. We're going to give them supplemental oxygen. PPHN, we've done a whole lecture on PPHN, but really PPHN is when that transition doesn't happen and the circuit that connects heart and the lungs together is not properly functioning and there's a backup of blood. There's a tightening in the circuit. So we often need INO to help us with this, but additionally we're going to use 100% oxygen to dilate those blood vessels. Apnea of prematurity, again, we primarily are going to treat with ventilation support. CPAP, ventilator, caffeine, right? Obviously, we've given caffeine probably to also our respiratory distress baby. So PIE, pulmonary interstitial emphysema, is where these kind of air trapping happens, right? So the alveoli leaks. I'm going to link a video from the Jet company on my Instagram page. So if you go check that out in the next couple of days, or message me and I will send it to you. It's public on their website. It's amazing, but it just shows you kind of what happens when the alveoli ruptures, and that's really what's going on with PIE, usually from overdistension, but that's severely going to affect your ventilation. So we need to get them on to either high frequency, whether that's the Jet or the oscillator, or get, whatever we need to do to support them with CPAP if they're not quite severe or they're weaning down. I've seen babies with PIE be able to get off the ventilator. I have seen it before. And then we're going to do some oxygen therapy, and then your babies with your normal pneumothorax. So pneumothorax is probably something that your unit tracks and trends to see what's going on. And if they are having a frequent pneumothorax or this collapsed lung keeps recollapsing, you may also see a change in your ventilator. So some symptoms that we see, right? We see these low sats. We might need to increase our oxygen. Is the baby anemic? When are they going to need a blood transfusion? We did a blood transfusion lecture recently and really talked about this idea that we are not just giving blood to everybody like we used to. I was talking to a nurse in July, and she was saying she gave a blood transfusion for the first time in about 15 months. She's a full-time working NICU nurse, and that's just the frequency that we're doing them now. It's not as common as it used to be, which is a good thing in many ways. Again, if you have PPHN, you might need some nitric oxide. Our PDA, our old friend, our PDA. So our PDA, also depending on which way it is shunting, right, from right to left. This idea, if you have a right-sided PDA, that means shunt. So your PDA is shunting from right to left. That means that blood from the right side of your heart is shunting over into the left side of your heart. So unoxygenated blood is just bypassing, going to the left side, and then getting distributed to the body. So you can see how there would be lower saturations, right? If you have a left-right shunt, that means that our oxygenated blood is getting back into the right-sided circuit and going to our lungs, where it already got oxygenated. Now it's going to get oxygenated again. Then our lungs get fluffy, they're edematous, they can't ventilate as well, so we're in trouble. Long-term PDA can contribute to poor ventilation over time. So lots of great information. I just listened to an amazing incubator podcast about closing the PDA, and should we be doing it? What are the outcomes? And of course, how is that dependent on ibuprofen versus acetaminophen, and then your coil versus your snipping? Great episode. I will also tag that in my Instagram stories, so go listen to that if you want more information. And then maybe your baby has pneumonia. Maybe we need some antibiotics. So there could be a lot going on. That's why ventilation and oxygenation are such a big part. I said that right at the beginning, right? Such a huge part of what's going on. And sometimes, I don't know if you've experienced this. I'd love you to comment if you have. You just figured a baby out with this great mode of ventilation, and then they don't like it anymore. And you got to start over. They like to keep us on our toes, those babies. But let's talk about how we can support their families. So we need to explain that ventilation and oxygenation are crucial. We need to use those plain words. Ventilation helps remove carbon dioxide. If you say CO2, I just feel like sometimes people are like, what are you talking about? So we need to talk about how ventilation is the process of removing bad gases and getting good gases in. Removing CO2, that we need some amount of CO2. We all know if our CO2 drops too low, we stop breathing, right? That's our drive to breathe. So cue my babies, my own personal third child, who used to cry so hard that she would hold her breath. Wasn't that fun? She doesn't do that anymore. She's 7 now. But we also need to make sure we're giving them enough oxygen, which also we can say this is why we have all these monitors on. And this is also why we are in here responding to high and low sats to keep your baby in a good spot. So I always talk about my elevator speeches, or things I say over and over again. Nurses and doctors are carefully monitoring and adjusting the treatments to keep your baby stable. We are tweaking our oxygen. We are watching our blood gases. Maybe we have a TCOM, right? A transcutaneous monitor on there watching our CO2s. Oxygenation ensures your baby's organs receive enough oxygen. We want to make sure that we're giving them just the right amount. Ventilation helps your baby breathe by moving air in and out of the lungs in a stable method to get the bad gases out. And then these processes work together to support your baby's overall health and well-being. So our next slide is usually a recap slide, but since I'm so into my charts these days, let's talk about the ventilation versus oxygenation comparison. This is just an overall recap of kind of what we're seeing here. So ventilation refers to the movement of air in and out, whereas oxygenation refers to the process by which O2 is delivered to the lungs. Our primary goal with ventilation, ensure effective gas exchange. With oxygenation, maintain adequate oxygen levels. So maybe you want to pause me, you want to snip your screen right now, you want to go to Instagram and add this to your favorites, go to TikTok, whatever it might be. But this is an overall recap of kind of everything I've said, tried to squish it into one thing. One thing that you will see on here is BPD, which we didn't talk about too much, but it is important to remember, especially if your unit is tracking your chronic lung disease, your bronchopulmonary dysplasia rates, right? You want to make sure that we're doing the best thing we can to help prevent this, so using gentle ventilation techniques, especially on our ELBW babies, and then making sure we're using the right levels of oxygen. And again, more of that, but down there, neurodevelopment. Remember, oxygen is brain cells. So stable oxygen supports brain development and reduces the risk of neurological complications. It is so easy as NICU staff to think, oh, the baby went home, everything went great. But we don't always know that to be true. So we have to do the best work we can, which you're all doing every single day, to support that baby, not just to get home, but to thrive throughout their childhood. So watching our oxygen is going to be a big part of that. So read through, snip, do what you need to do. And then here are all the places that you can be following me. You can scan this on your phone. If you're on your phone, you can find me here on YouTube. Make sure you're subscribing so you know when you're getting your new videos. On Instagram or TikTok, where you can find all of my Teach Me Tuesdays in just slides. I do not talk on them. So if you want to just go and get my slides, they are available there. And of course, other fun and educational opportunities on Instagram and TikTok with lots of interaction and often prizes. So find me and follow me in all of those locations. Have a great Teach Me Tuesday. Thank you for joining me. Next Tuesday will be the first Tuesday of September, which I also believe is my husband's birthday. But I will see you then for another new and exciting NICU topic.